Good morning, everybody, and welcome to the next edition of the EMS Spotlight. We have a few things to go over this morning. We'll try to make this one a fairly short one, maybe 15 or 20 minutes. And as a reminder, we would like everybody to watch these. We give you the most important points of what happens in our system. We get this stuff from the CQI meeting, from M&Es, and all the important points about what we feel we need you to know about what's going on. We try to keep it short. We have a lot of different topics we will talk about, but this is, we consider, probably some of the most valuable information that you'll get from the physicians during the year. We only do this once a month. We try to keep it short. Please, please, please do everything you can to review it.
Yeah, so let's talk about airway first. You guys are doing a great job. Just some facts and some numbers here. The average time between attempts, so if you're not getting the airway on your first attempt, we're averaging about 4.5 minutes, and that's actually good. We want you guys to remember to take some time after that first attempt, try to troubleshoot or think what caused you, why you were unable to get the airway on the first attempt, and you know, we're usually getting the airway on the second attempt. Always remember, if it's not a failed airway, if you're not able to intubate, we'd like to see, you know, make sure there is the IGL placed, you know, if after your attempts you're unable to secure that airway, and IGL is a reasonable option, and we definitely would like to see that. And we've had 96% of the patients have received an advanced airway of some sort, and 75% of those were with endotracheal tubes. Some more facts here. Just saying, you guys are doing a great job. Like we've been hammering all year, especially with the airway courses. Just slow down, take your time. You know, make sure you're using the video-assisted airway, video-assisted laryngoscope is your first option. Walk the airway, look for the epiglottis, and you know, you should be able to see the cords and identify the structures as you go down. So just remember that slow is smooth and smooth is fast with that.
Great.
And just moving on to RSI. Hey, you RSI medics are doing a phenomenal job. We had 2 RSI airways that were both successful. So we have a 100% success rate. One thing, just remember your documentation, and always pull up all the medication, including your post RSI sedation medicine. So make sure you have that Versed drawn up and ready to go, because we have had a few airways, you know, in the remote past where we haven't done the sedation. So just remember, it's all part of a bundle, and if you're going to take somebody's airway and secure it, we need to make sure that they're being sedated for the procedure. Also, we want to point out, try to get 2 IV access sites, and the reason why you want that is in case you have a problem with the initial, you know, IV access site. You need another place to push the paralytic or the you know, sedative medication. So if you can get 2 ahead of time, you know, after you're trying to push the paralytic and it infiltrates, that's not a good time to try to look for a second IV site. So try to get 2 set up before you RSI the patient.
All right, the next subject here is ketamine. So with we'll talk about sedation first. We use ketamine obviously for 3 different indications. One being an induction agent for our RSI, which hasn't really been an issue at all. We also use it for sedation for extreme agitation or excited delirium. Originally, when we came out with ketamine, we always labeled it as the patient must have excited delirium. However, what we were doing was we were pigeonholing you into an exact diagnosis, which sometimes was very difficult on you, and so we changed it statewide to extreme agitation. We have in our system been starting to see some creep in that, where people are starting to get ketamine for just average sedation, for average agitation. If they're drunk, or if the paramedics want some prophylaxis sedation, We really want to stick away from that because the state monitors this very closely. The research nationwide, not just locally, is showing that at sedative doses, there are some adverse outcomes, one of which is that 30% of the people given that dose of ketamine end up intubated, and it's not just because the emergency department physicians aren't used to ketamine, which is what we originally thought. This is something that's been repeated and repeated in the literature. There are also other reasons that we're seeing that are making us just raise our eyebrows a little bit more and be a little bit more cautious about this when we use it for sedation. It still holds a place. It still holds a really good place. And so we want to make sure that we're using it correctly. We're using it for the times that we really need it. It needs to be for extreme agitation only. If you have moderate or mild agitation, please go to our old good backup, which is Versed. When you document ketamine being used for aggressive patients, make sure that you're using the term extreme agitation. If you want to, you can say excited delirium if you know for sure. Saying that you just did it for crew safety doesn't really meet the marks that we're looking for. Of course, we want you to be safe out there, but if you are really, really scared for your safety, then that would fall into the category of extreme agitation on the patient's part. I think all of you are familiar enough with the types of patients that we're talking about that have extreme agitation versus just sort of the normal run-of-the-mill moderate agitation, and let's try not to be using it prophylactically. The state does monitor this. We want to make sure that we can keep this as a waivered usage for ketamine. For pain management, we've had some cases recently where a common practice has been the entire vial of ketamine is drawn up, or a large amount of ketamine is drawn up into a large syringe, and then you only give a very, very small amount of it, obviously, for pain management. When the ketamine is drawn up in a large syringe, even if it's something that you fully know you're only going to be giving a certain amount, it sets you up for a potential failure, a potential dosing error. It does happen. We are having consistent mistakes, not many, but they are consistently rolling in. It's not like we only have them when we first brought ketamine out and now they've disappeared. And every time we look back into this, it's because the ketamine was drawn up in too large of a syringe and it was accidentally given. And so if you are calculating out pain management ketamine dosing and you are drawing into anything larger than a 1 ml syringe, you need to stop and you need to figure out why you have basically miscalculated because you're going to be giving too much. That's more than what the pain management dose is. And so it's kind of a good second check and balance. Please, 1 ml syringes, and we're asking people now to, preferably if you can, push it into a 50 cc bag and drip it in rapidly. We find that that has cut down on the adverse side effects tremendously, the dysphoria that patients can get. But good use of pain management on ketamine, and we use it a lot, and we're planning on keeping use it, and so good job.
All right, I'll talk a little bit about stroke. Okay, so remember, if you have anybody that you have a suspicion of stroke, use the BFAST tool. We know it's not perfect, but it's what we got. And so make sure that, especially if they have any abnormal balance or eye deviation, that's highly suspicious for a posterior stroke. And we want you to activate a stroke alert on those patients. And remember that if the patient is positive for BFAST, we want you to do a CSTAT score, and we definitely need that score documented. People are looking at this score. This tool right now, the CSTAT tool, is the best tool we have. We realize it's not a perfect tool. We've looked at all the tools out there, and none of them are perfect, unfortunately, but it's the best we got. And so we would like that CSTAT score documented. And remember, if the score is 2 or higher, then that kind of helps drive your destinations. And just stick to the destination guidelines. There's been no changes to the destination guidelines with the CSTAT of 2 or higher. So But good job on the strokes. You know, remember that just activate that stroke alert on Pulsera if they're positive for the BFAST.
Yeah, and I'm just going to reiterate one thing that Brett mentioned, that the reason why the CSTAT is so important is that that's what we use to drive our destination guidelines. That's what can potentially make you bypass one facility for another facility in our city. And so, so it is important to document that, because that's what we rely on to go back and systematically evaluate, do our CSTAT scores match up with why we are bypassing the closest facility. So it is a really, really important CQI tool for our system.
Yeah.
Okay, so little reminder about Pulsera. Please use the general alert if you want, if it's a non-STEMI, or you have any other type of patient that you want to ask a question on, but the circumstance we're really running into is when people get out there, they have an EKG, you say, oh man, this may be a STEMI, it may not be a STEMI. I'd love a doctor to be able to take a look at this and see. The general alert is perfect for that, because you can patch in with the general alert. The charge nurse can show it to the physician can look at it, they can give their 2 cents about it, and then give the information back to you, and then if you need to activate a STEMI alert, you can. But if you activate STEMI alerts on all of the EKGs that you just have questions about, it activates a whole lot more within the hospital system than just giving the information to the emergency department. And so that's why we want to promote using the general alert if you just have some questions. If you don't have any questions, that's great. If it's a STEMI, you think it's a STEMI, just put it through, and then we activate it and everything. So please remember, general alert is there for you to run things by the physicians, especially EKGs. Anything on that?
Well, and I was just going to say, yeah, remember, you know, if you push it through as a general alert, again, like Stein's saying, if it's a STEMI, it's a STEMI. Don't hesitate to call the STEMI alert. But if you're having questions, if clinically the patient doesn't look like a STEMI, but his EKG's got some changes and you're not sure of, by doing the general alert, not the cardiac alert, as physicians, we have access sometimes to their old EKGs, and that helps us a lot because we can compare what you're seeing out there on your 12 lead versus old ones, and then that kind of can help drive some of the management with the patient. So don't hesitate to just use that general alert for that or other issues if you just need to talk to a doctor about something.
That's a good reminder that what we always tell you on an annual basis or even more, smart is good, but old records are better.
Yeah, definitely helps. It's one thing EMR is good for.
Yeah.
Just real quick here, you know, I don't think this is a huge problem, but just if you see a patient and you suspect that they need decon before you're bringing them into a hospital, just remember to put that through on your patch. You know, this is for if there's a fluid exposure, including, you know, gasoline or any kind of toxic fluid, and then any kind of infestation. If you you know, find one of those bed bugs, in Texas we used to call them unicorns, on patients, so we wouldn't freak out the other patients by it. But if you see any of those on the patient, just let the facility know, because if not, and we find them in the facility, especially like bed bugs and stuff, then we have to do a terminal clean, and it just takes more time, and it shuts down a ED room for a while until we can get it terminal cleaned. And then obviously with fluids, we want to have the correct protective, personal protective gear on and stuff, just because we want everybody taking care of that patient to be safe if it's a noxious fluid.
Absolutely. All right. It would be much appreciated by the ED staff if you can give that pre-warning. One last thing. Some of you may or may not have heard of this yet, and it's becoming a point of confusion. So everybody knows what an M1 hold is, or have heard what the concept of an M1 hold. This is historically, no matter how long these things have been around, have always been a point of confusion. Who can place it? When are they real? Do you have to have the original paperwork? Do phone calls work? All of this. This is a topic that I've just realized after 11 years of being in the community that we're just going to have to go over it again and again and again and again, which is fine. But this is a change now, all of a sudden, that's come down, that there is some misinformation being circulated, unfortunately, or some poorly verbalized or written down information by a hospital in Denver, actually, that has now made its way down to Colorado Springs. And so I wanted to clarify this. An M0.5 or an M1/2 is a new type of psychiatric hold that has been developed that is really a transport hold. Now, you would think, oh my God, let's celebrate now. All of a sudden we have a hold that EMS crews can put on the patients and they can transport them in and everything. That is not the case. I don't care what the paperwork says that is circulating around from Denver. I've checked this out at a state level, the people who wrote this out. That is not the case. An M0.5 is a hold that can be written and placed by the same people who could write an M1. That's law enforcement, a licensed social worker, a physician. As far as we know, it cannot be done over the phone. But what it does is it allows those type of people, especially law enforcement, and well, all of them actually, to say, I've encountered a patient who's sitting in front of me, and I'm not 100% sure that they need to be placed on a full M1 hold, but boy, I would like some other means of being able to hold them and get them to be evaluated. This fills that gap for them. It doesn't really do a whole lot for EMS. It doesn't put us in a worse position. And we've actually done a pretty good job, I think, locally of working through that gray area. And somebody being on an M0.5 hold is no different to us as EMS providers as somebody being placed on an M1 hold in the field. They have a hold that is against their will, and you're going to be transporting them to the hospital. If they actually have the hold with them written out, it has to be, written and everything, then yes, they can be transported. We deal with a lot of gray areas where, someone says, I think this person needs to be placed, but I'm not going to write this paperwork out, or you're not dealing with law enforcement or a licensed social worker or a physician, but you encounter somebody that's suicidal, and then we get back into that. Let's insert ourselves into our favorite hamster wheel, where we say, okay, what do we do with this patient? So we go back to the same thing we've always told you. If there's no hold that's already been placed, and you feel as though the patient really needs to be evaluated, do what you can to bring the patient in. We will always back you, and it's easier for us to back you if you bring them in. Do it keeping safe. Don't put your own safety at risk. And if there is an M0.5 written or an M1 written, that's great. That's even just more stuff. You don't even have to debate about it. But really, for EMS purposes, the M0.5 is no difference to us than an M1. It just we're going to be transporting them. So I'm sorry for the misinformation that's been put out there. Specifically, there's some misinformation that states that EMS can place these types of transport M0.5 holds on patients. That unfortunately is not true. So we'll help clarify this again and again and again. I just wanted to bring it up because that paperwork has arrived in Colorado Springs. Anything else on that?
No, I think you said it well. So just again, it's not changing anything from us on the EMS side. You guys are doing a great job. Just keep doing what you're doing.
And that's about it. As always, if you have any questions, you can contact your CES office or Med Division office or your supervisors. You can contact the physicians directly. And please put it out there that we really do want everybody looking at these spotlights. It seems to be a recurring theme that we answer questions in these spotlights that are asked again and again and again. And we know that it's a cultural change to start watching them, so we appreciate those who are, and prompt your colleagues out there to do the same. Thanks a lot, and have a great day.